Well, good morning, everybody. Good morning. It's a little past 10, so we're going to go ahead and get started with our Health and Hospital Committee. I'm Supervisor Ken Yeager, Chair of the committee. Supervisor Simidian, who is Vice Chair, will be along with us shortly, but he asked that we go ahead with the meeting. And so we've called the meeting to order, and we move on to public comment. And we have a couple speakers, Scott Largent and Leonard Williams and Dr. Ken Horowitz.
All right, ready to rock and roll. I had a really good week last week. On Thursday, I finally got to see my daughter. Yesterday, she actually turned 3. I had a supervised visit. I went for 2.5 hours. When I went through the door, daughter's eyes opened up, and she recognized me. She remembered me. We didn't think that was going to be the case. It was probably the best day of my sobriety, being able to see my daughter. I've waited for that for a long time. My daughter became like a drug to me. Getting over addiction and then becoming addicted to my daughter, and you know, I should be very happy that this has been able to materialize, but I just keep wondering why it took so long. I keep wondering, am I just somebody, is it rare to have somebody at my age not on probation, not on parole, trying to get drug assistance from the county, trying to access all these resources? Is it just that this just doesn't happen? Am I just that one small percentage? And that's what I really want to try to figure out. How many of the other mentally ill, homeless people that have drug problems in our little zombie apocalypse down there have maybe tried to do what I attempted to do? I mean, how many of them down there fought and fought and fought? And I'll tell you, there's hundreds of times I was going to give up. And I want those people to have hope. So when they go through this system here, how do we get them back into their kids' lives? How do we take these court orders and have them enforced? How do we work with the family to let them know, hey, look, these people that are coming through our county that are using these resources, they are doing the right thing. They are getting, you know, just none of that materialized. So I'm glad I have these visits. I have to work on things with my ex to make sure she understands that I'm clean, that I'm sober, that I'm doing the right things, because I think she's just clueless and just doesn't know. Nobody advocates for somebody in my situation. I cut off all ties with everybody I did drugs with, even people that I grew up with, just to make sure I had that completely sober environment. You know, I live with my grandmother, I interact with her caretakers, and you people are the people I see all the time. So I don't think she really knows. So I'm working on that. Tomorrow I have another visit for 2.5 hours. This should have materialized, like I said, years ago. I have to pay hundreds of dollars an hour to see my daughter. I will make that happen, and it's good they provide these reports for court. And once I get the thing from our probation department for my drug diversion charge, which was basically slap on the wrist, it's not put on my record, I can go back in front of the judge and fight for half custody of my daughter. So I'm really, really that close. I just really want these people to have hope. I just really do. So it might sound weird. We got a lot of smart people, but none of it really panned out that way. So good. Thank you.
All right. Lenny, why don't you come forward? And Dr. Horowitz, why don't you come forward as well?
Good morning. I'm Leonard Williams, and I'm proud to be back. I'm so happy. I spent 21 days at the Sombrado building from February the 13th till March the 1st, and I will want to tell you, that is the most beautiful facility I've ever seen. The staff there cannot be beat. The nurses, the doctors, even the people that clean the rooms, all the way down. You can't beat them. They're the greatest. And working with Benita and Paul and all of them, having them back us up as a PFAT, we got the greatest group going now, and I am not quitting. People ask me when I'm going to retire, when I'm going to leave. I think it's when they bury me, then I'll be done. But I want to thank everybody. I want to thank
Many years from now.
I hope so, Ken. I want to thank my backup, my partner in crime, Bob Gazinski, we're inseparable. I've given speeches to different organizations, and you can't work with a better staff. I work with Benita, I work with Paul, I work with them all, and they all came to see me when I was in the hospital. They tried to get down to see me. I was on the 3rd floor, room 119, therapy. They have the greatest therapy going. My person that I work so well with in customer relations, her name is Stephanie Wynn, and she has been great. We work so good together. And I can't say enough about our hospital and our clinics and our doctors and our nurses and everybody. And I want to thank everybody for backing us, because PFAT is really an honor to be on the team, because they don't lie to us. I started this 3 years ago. I remember Steve Preminger saying, you know what, let's see how long you last, because when you get on something like this, he said, I know it's going to work, because he says, you only get on things that work good. So I want to thank everybody, and I am so proud to be back with a group that I love so much. And I'm going to keep working my rear end off as long as I can for the hospital, for my clinics, and for everybody, for the patients. So thank each and every one of you, and I am so proud to be home again.
It's good to see you again, Leonard.
Good morning. My name is Dr. Ken Horowitz, and I'm a member of the Health Advisory Commission, but for this particular item, I'll be speaking as a resident of Palo Alto. I just want to bring to your attention, particularly to Supervisor Yeager, because I know this is something you're very much interested in. On Monday night, this coming Monday night, the City Council of Palo Alto will be discussing a potential ballot measure to address obesity, diabetes, and all the other chronic diseases that occur from soda. And so on this Monday night, at about 6:30, our Palo Alto City Council will be discussing a ballot measure in regards to a sugar beverage tax, a soda tax. And hopefully, at the current time, they have spent money on a fund to look at the data, whether our residents would support such a measure. And hopefully we should know the results tomorrow in the evening, what the data shows. But I think the Palo Altans will support a tax. And on Monday night, the City Council will undertake to support a measure for the November ballot. So I just wanted to bring that to your attention.
Thank you, Dr. Hurwitz. I noticed too that you fill out an item for item 16, which is on the consent calendar. Would you like to speak to that now?
Is that the one regarding
The annual reports?
the
annual
annual
work plan.
reports? Yeah, I didn't. I just wanted to call your attention, because normally those things on the consent calendar get overlooked. But as a member of the Health Advisory Commission, two things that I wanted to call your attention to, and I'm also going to bring that up in item 12. We sent a letter to the Board of Supervisors regarding staffing of the dental clinic at City Team, and I didn't see that on the inventory, so I will address that a little bit later at number 12. The other thing is, hopefully, if this thing passes in Palo Alto, the sugar tax, that the Board of Supervisors will consider implementing that in the unincorporated areas of Santa Clara County as well.
Good.
So something to think about in the future.
I've been thinking about it for quite a while, so
I know you have.
All right.
Thank you for your time.
thank you. All right. We will go back to the consent calendar when Supervisor Simitian arrives. So we'll move on to number 4, which is consider recommendations relating to medical staff.
Good morning, Supervisor Yeager,
Morning.
County Executive Dr. Smith, honorable committee members. I'm Dr. Thomas Winsing, President of the medical staff. I'm here to present the monthly credentials report, and we'll answer any questions you have.
Thank you. We will officially approve them when Supervisor Simitian arrives. Number 5 is the verbal report from the health officer.
Good morning, Supervisor Yeager. I just have a very short report today. Quick communicable disease update. School is getting out, which is good because we're having outbreaks of pertussis in high schools and norovirus in elementary schools, and so they all need to be separated from each other. Second, I just wanted to give you a little update on our work in diabetes prevention, because I can't recall if you're aware that as part of the Transformation 2020 effort, we have a diabetes prevention work group, and we've really begun to dig into some systems issues, uncovered a lot of really important information, and have a very strong multidisciplinary team looking at how we improve things. So it's there's quite a bit of energy, and it's going very well.
And you'll give us a full report on that when it's ready?
I think it's part of the T2020 reports that you'll get broadly, yeah. But I just wanted to highlight that for you because I knew you would want to know. And the other, I just wasn't certain if this committee was aware, this is very important to public health. Our dear Amy Reedy is retiring as of July 1. And we are actively recruiting.
I asked Dr. Smith if he could intervene in that, but apparently his powers only go so far.
I might, quarantine her to the county and not allow her to leave.
She was looking a little pale the last time I saw her, so maybe quarantine is in order.
Anyway, as you know, public health is very, very, very much a team sport. And so we will miss her greatly. And we hope to have some good applicants and keep our team strong. That's all I have.
Excellent. And just because I thought it was interesting in yesterday's New York Times, it's always nice to get the print version. They had actually a very nice story on public health spending saves lives and money.
Yes.
And I could read the whole thing, but I won't. But it says not only have many public health interventions in the United States been hugely successful, but they've also saved more money than they have cost. And yet Americans spend relatively little money in that domain and far more on medical care that returns less value for its cost. Instead of continually complaining about how much is being spent on health care with little to show for it, maybe we should direct more of that money to public health.
As a follow-up to that, there was a fascinating interview with Atul Gawande on NPR on just this topic, and he poses some reasons for why this might be the case.
Excellent. All right. We are joined by Supervisor Simidian, and we've made a little progress. So if we could then get a motion to approve our consent calendar, which is 3, and 4 is the recommendations related to medical staff, and also then the verbal report from the health officer.
If it's agreeable, I will move all 3.
It is agreeable, and we approve that. And we move on to item number 6, which is to consider recommendations relating to the monthly report from the Director of the Valley Health and Hospital System.
Yes, and good morning, Mr. Chair Yeager and Supervisor Simidian. I have a written report that gives you pretty much a legislative update at the state. We don't have Bert Margolin. There's not much of a federal update, although he'll be back in June to give us pretty much a fiscal year wrap-up of whatever latest is going on at the federal government. One of the things that highlighted in my report is what the progress that we've been keeping you and your committee up to date in terms of all the waiver-related programs. We'll be asking for an extension of delegation of authority. Thanks to Dr. Smith's support and the partnership with Community Health Partnership and the community clinics. We have the latest data in terms of the PCAP program, the number of uninsured that we're serving in partnership with the clinics, as well as you saw last month, highlights of the progress on whole person care. We'll give you a summary of the number of contracts that have been agreed to under the delegation. It's not just for service, but also for data sharing in terms of data use agreements. And if there's any questions related to that, I'll be happy to answer that. Finally, we'll also have our latest UBTs, and I think this is an ongoing successful story. As we indicated last month, we're asking for some staff to make that permanent as part of our regular work, but I really appreciate the employees and the staff for embracing that labor management partnership. That concludes my report, unless there's any questions.
Just one quick question. How worried should we be about the May revise still proposing changes to the 340B program?
Yes, this is the proposed governor's elimination of the 340B program for safety net providers. We're a little bit encouraged that the expected savings do not kick in until 2021. which means that obviously the governor's administration heard from the hospitals as well as the community clinics of how critically important it is to continue to receive these discounts from the drug companies. We're hoping that also the legislation, at least the indications, they were not necessarily in favor of the governor's proposal, although they may still make it as one of the budget issues when they go and confer on that matter, but at least gives us a little bit of time to continue to work with the state administration to at least minimize, if not eliminate, the compliance risk in terms of reporting to the federal government and the state without necessarily eliminating the program. So at least we're encouraged with the change in the administration's position at this point in time. We'll keep you posted as it moves along.
Great, thank you, Supervisor Smitty. And any questions on 6A? 6B, there is no report, and 6C is received report from Behavioral Health.
Good morning. I just have to scoot over next to Bruce. There's a lot of detail in my report. I wanted to highlight a couple of areas, and the one that I think is most important and relevant is that the department scored 98%.
Congratulations, that's huge.
And that is, I want to emphasize how significant that is. It's really not only a sign of organization and development of policies, but I think it's a real reflection of where behavioral health is headed. Many staff were involved in this, and it was really exciting to see in section after section, the DHCS team said you have 100%, 100%, 100%. So I want to celebrate that. There is a second component to the audit that is the chart review, and we are waiting for their comments about on the charts that they reviewed. There were 20 charts. 19 of them were in the CBOs. One of them was a county-operated program, and we should get that information within the next month. So that's something else I'll be reporting out on. I think the other big item in the department that's described here is the MHSA draft plan is now up. We are identifying times to meet with all of the board aides to walk through this so that well before this comes to the board, you are informed about what we're doing and what where the money's going. I think the plan is very detailed on a number of programs in a new way that would be easy for board members and community members to see what's going on. And the third thing that is both in my report and in Renee Santiago's report is we are doing work right now with the substance use county side that's described in here, just given issues that we have with compliance, and a meeting is being set with the executive's office and with Renee to provide information from compliance, council, and then behavioral health. So those are the big three I'd highlight. Do you have any questions?
No, just again, congratulations on the audit, and even though I know it was 98%, which is great, certainly in almost other categories it was 100%. So that was great. On the sobering center, it was I was glad to read that the EMS from Gilroy at least are going to the sobering center, and maybe we could try to get that county-wide, because I think that's
there's a pilot
perfect,
there.
yeah.
I will say that we're seeing an increase of clients going into the sobering center, which is really exciting for us. And there has been an incident, I shouldn't call it an incident. There was an opportunity with somebody was at VMCED who needed that, and the van went and picked him up and brought him over to the sobering center. So all the things that we had planned to do are now in place, and we're seeing more utilization.
good.
So.
No, it was an excellent report. Supervisor Smitty?
Just one quick question, because I can't resist the opportunity to ask. Are we on track to, speaking of access, are we on track to make the Aspire program available to Medi-Cal
Yes, we are. We're having those conversations.
July 1st?
I believe it's July 1st. I can confirm with your staff, Supervisor Simidian, but I know that there's a lot of work underway on that.
Great. If I could ask you to circle back with my team, that would be helpful.
I will do that.
Thanks so much.
And we have one speaker on this, Scott Largent.
Hi, thank you. I was reading over the report in the back, blah, blah, blah. What I was hoping that eventually, I was at the reentry network meeting, and I'm not sure what the doctor's name was, but he was on the panel. He was talking about how you still have to get on a waiting list to get into drug treatment. I've been going to these meetings, for about the entire distance of my sobriety, and I just think when somebody wants to throw in the towel, we need to help that person right away. And I don't think that, you end up having to go through the legal system. Well, what if you're not getting arrested? What if you're, not on probation, not on parole? Why can't we open up the door with these different programs for people that are not getting arrested? That really is mind-boggling to me. Like the reentry center. You cannot use the reentry center unless you break the law. And I understand it's re-entering the community after drugs, after mental health issues. I think anybody should be able to walk over there and ask for help. And I think it should be the same way on a behavioral health end. Like I said, doors slammed in face nonstop. So what do we do to fix something like that? And I know there's a lot of work, a lot of things changing. I go out to different encampments and even downtown now, and I bring my little camera, and when people want to participate, I sit there and ask them all these questions. And a lot of people that I'm meeting with, they enjoy interacting. I mean, maybe it's the fact that I was a meth addict for a couple of years, and maybe the fact I don't have teeth. Just my experience is they're very open to talk to me. And I'm trying to document this to figure out what doors they are still getting slammed in their face. I was very disappointed to hear the doctor on the panel say that, because that's what I dealt with 2.5 years ago. So it's not all a failure, but that part of it is. Somebody should be able to walk in, say, I'm throwing in the towel, and that's when the county steps in and says, hey, this person wants to get off drugs, they want to take their medication, they want to do the right thing. Let's help them do the right thing. Don't make it too hard. So thank you.
Thank you. We move on. We'll get a motion to receive that report.
So moved.
That we pass it on. Item number 7 is receive report from the Valley Health Plan.
Thank you and good morning. I will offer some highlights from our monthly and quarterly reports. As of the period ending March 31st, Valley Health Plan's administrative expenses are running at a fairly strong, favorable variance to budget. Enrollment patterns continue as we've seen them over the prior year with some declines in Medi-Cal, increases in commercial membership, balancing out to a flat enrollment result in total. Within Covered California, as part of the commercial plan, with things settling out after open enrollment, we are kind of zeroing in on a little bit under 13,000 members in total. I do want to recognize, although she's not here in person, the appointment of Deborah Halliday as Valley Health Plan's Chief Operations Officer. That became formalized a couple of months ago. We're very pleased and fortunate to have Deborah as part of her team, and she's bringing in some great experience from national managed care organizations in addition to her previous work with the health and hospital system. And then finally, I'd like to point out the inclusion in our quarterly report of Valley Health Plan's Utilization Management Policies and Procedures Manual, and just reiterate that we would, of course, welcome any dialogue and discussion from any board offices who would like to engage with us on that at any time. Please feel free to reach out to either myself or Dr. Goyle with any questions about that. And with that, I would defer to any further questions that the committee might have.
All right, I don't have any, so we'll make a motion and
So moved.
send it on its way. Item 8 is report from Valley Medical Center relating to operational and financial updates and efforts to hire and retain experienced nurses. We do have a number of speakers on this. Paul, I don't know if you have a sense of, do you want to cover non-nurse items first, and then we can then go to that report and then hear public testimony?
Thank you, Supervisor Yeager. That would be fine.
Let's do it that way then. So we'll start then with, I guess it's mainly the operations and the financial parts. I'm trying to look through here and see what else is in your report besides the nurses.
We do have a financial report.
Why don't we do that? Just do that first, if that's okay.
So, John?
Yes, kind of happy to report April results, and we got approval from CMS for a couple of programs that we were not certain about, and we have in April the catch-up for the EPP program. So revenue exceeded the budget in April by $41 million. So net income for the period was favorable to budget by about $43 million.
Congratulations, that's great.
On a year-to-date basis, we have no slide.
Well, I think I threw everybody off by switching the order, but Amy might be working on it at this very moment.
You can see the year-to-date impact of QIP and EPP. Those were programs that were a replacement for MCE to cost and SPD to cost, where we were given supplemental payments to bring our essentially capitation amounts up to the cost of those services. And so those are the year-to-date amounts that we've added over the last couple of months. So favorable to budget on a year-to-date basis. Revenue is about $15 million ahead of where we plan to be. And I think probably it's fair to say that, probably 40% of our overall revenue is from those programs, and the balance of the program is from the delivery of services. So again, net income-wise, we are $40 million for the period, and favorable to budget by $64.3 million. The monthly billing production was strong, and it translates into a greater level of collections. Next one. If you look at the monthly cash performance for the month, we collected $87 million, and you can see that that's the best that we've done on the periods covered by this slide. Last year we averaged about $63 million a month, and for the 10 months of this year we've averaged $68 million. And then the last slide shows you that at the beginning of the fiscal year we were at a little less than 58 days of revenue outstanding, and we've struggled during the year, but we're finally back to that level. Part of the problem was they changed the billing format for FQHC services, and there were some issues with revenue codes being set up in Medi-Cal. So those things have been resolved, so we've been able to get back to the level we started out at the beginning of the year with. Happy to answer any questions anybody might have.
Well, certainly great news about our net income is so favorable. What are we planning to do with any surplus that VMC might finish with at the year? Will that money stay in the enterprise as a reserve, or maybe go back to general fund?
I'm looking at another direction. The suggestion is it might not stay. The only caution I have is that we've got 2 more months and we have end of the year stuff to take care of.
We're capturing that into the general fund by reducing the subsidy recommendation for next year. And in response to the concerns, we have established pretty clearly a policy that reserves will remain in the general fund pretty much across the board, and if they're needed, we'll recommend that they be returned to the enterprise fund.
All right, a good problem to have as far as we're to
helps balance the budget.
Yes, no.
Well, I should point out, the dramatic improvement that has happened with the hospital and the health system has really helped that system, because we've added 1,000 employees and added new services and been able to add IT and build buildings for services, and all of that, and we've also been able to lower our general fund subsidy. So altogether, it's a fabulous effort from the team, and I think, I know that the board recognizes that. I hope the public recognizes that they've just done an absolutely fabulous job, everybody in the entire system.
Certainly, 10 years ago when I joined this committee, our charts didn't quite look the way that they look now, and it's really nice to see all the bars that are above the red line rather than all the bars underneath the red line. So, Supervisor Smith, you have your light on. Any questions on that? All right. So then, we're going to go back to the nurses section of this report. Paul, do you want to then introduce this?
Sure. Thank you, Supervisor Yeager. And as we know, this committee was asked to review our efforts around nursing recruitment and retention at Valley Medical Center and also in the health and hospital system. So at this time, I'd like to introduce Jill Sproul, who was our Chief Nursing Officer, to give a report, and then we can take any questions that you may have.
Good morning, everybody. Supervisor Yeager and Supervisor Smidian, I really want to thank you for the opportunity to give feedback and update you on what we're doing with nursing. Over the past couple months, nursing administration has been working collaboratively with RNPA leadership to really look at the data and look at what we're doing in regards to recruitment. And during that time, it's very apparent our goals are aligned. I think we both want the same things: the ability to hire experienced nurses, of course, retain top talent, and really create a structure and infrastructure for professional growth for the nurses. Of course, encouraging advanced practice. That is the new horizon for nursing. And we are really dedicated to training new graduates. We need to invest in our workforce, depending on what you read and what part of the country you're in. In parts of the country, the nursing shortage is here. California hasn't been hit as hard, but we are anticipating a large number of experienced nurses leaving the workforce with our aging baby boomer population. So we really need to invest in new grads. And my goal as a CNO is I want everyone to flock to VMC and just be the employer of choice, like Google is to the tech industry. And if we look at year over year, as our average daily census has grown, our outpatient clinics has grown, we have added positions. And so over the course of the past 3 years, we've added additional coded funded positions. And if we look at our vacancy rate, we are making progress. We recently, thank you very much, added 47 additional clinical positions to help with our ICU bed expansion, the ED, and the operating room. And despite, if you look at the top graph, in July of 16, we were at about a 9% vacancy rate, and currently we're running about 7.52. And
Jill, I'm just going to stop you there. And how does that compare nationwide?
Well, nationwide is anywhere from about 6% to 18%. But here in California, UCSF did a study about nurses in California, and the rate in California is 11.6%.
And again,
that's turnover rate. But again, we're under for turnover and for vacancy rate in California.
Great.
So underneath that is custody, and Matt Guerrier couldn't be here today, so I can certainly report custody is higher than inpatient, ambulatory, and psych, running at about 16% vacancy rate. As far as why people are leaving, it's very important to us if we do have coded people that are leaving, why they're leaving. And so in 2017, we started doing exit interviews, and the breakdown of, can we go, sorry, go back. We did have 52 nurses retire, which is a good thing, but unfortunately it's at a much faster rate than in prior years. And 80%, well, I guess fortunately, or unfortunately for us, but 87% are experienced nurses, are CLIN 3s. And our annual turnover rate of 6.8. You can see by the chart here, the majority of nurses leaving are clinical nurses. Okay, now we go to the reasons. So when they started doing the exit interviews, they wanted this to be confidential so we could get truthful and accurate information. And we looked at the top 5 reasons: family obligations, changing to per diem status. So they stayed within the county, but they wanted more flexibility in their life. So we didn't really lose them, but we lost them as coded employees. But they stayed with us per diem. Unpleasant work environment, and unfortunately that's kind of a broad statement, so we don't know if it was peer-to-peer or if their manager or just the patients, the clinical area they're in. The fourth was kind of tied with the third: work schedule, work-life balance, depending on the shift in the code. And the fifth reason was moving out of the area. And I know of specific examples. People are going to Oregon and they're going to Las Vegas because the cost of living is so much cheaper and the housing market is pretty hot here. So we absolutely depend on our extra help and per diem nurses to help provide a flexible staffing model, because we need the ability to maybe flex up by a census of 40 over 2 shifts and flex down if we have a lot of discharges. So many hospitals actually run on an 80-20 model, meaning 80% of their nursing hours are from coded, benefited employees, and 20% are agency, per diem, and extra help. We run closer to a 90-10 model, meaning 90% of our staff are coded, and that 10% of our per diem and extra help actually are extra help and per diem hours. So we're averaging about 9.9. And if you look from January of 17 to February of 18, the 2 highest months of extra help utilization was November, in which we were doing a lot of training and planning for the opening of Sobrato, and we had to backfill for education. And then, of course, February being the worst flu season in a decade, so we had a very high census. If we look at how do our extra help nurses fare with going into coded positions, of 122 new hires for calendar year 17, 87% were extra help or per diem, which is really a win-win situation for us because they don't require any training, orientation, and it's a way to help retain them into a coded benefited position. This is for custody. They hired quite a few per diem nurses, and they hired 46 actual extra help and per diem, and they had 15 leave, and they were able to get some into coded positions. Again, any questions for Matt, we can certainly defer when he's able to answer them. Recruitment of nurses. I'm happy to say a couple years ago we were able to add some resources. So we have someone that's a whiz at social media, which is just widening our, everyone goes online now to look for jobs, not like when I was looking for a job. And so the use of, Twitter and Facebook and all these efforts has really helped with our applicant pool. And so this data was provided by Nursing Recruitment. And if you look at the CLIN ones, we do not have any problem with 1,800 new nurses applying to VMC. And you can see from before social media to after in the CLIN 2 area, we've really increased our CLIN 2 applicant pool, and we're kind of staying steady with our CLIN 3 applicant pool. But that's not unusual. I meet with all the CNOs in the area quarterly, and the experienced clinical nurses is an area that people are having difficult with, specifically OR, ED, critical care. But we have had some success, and we are able to hire experienced nurses. Our OR manager has just recently hired 6 experienced OR nurses, 2 with 20-plus years of cardiac experience, which is unheard of. And our manager of CCU and MICU has just been able to hire 5 very extremely experienced critical care nurses. So we're very proud of our training programs. Being a teaching hospital, we do train a lot of nurses. And our medical surgical training program and critical care training program has been around for decades. The training involves for med-surg, 8 weeks, that's minimum. And for critical care, it's longer, 12 to 16 weeks. And I have to say I'm a little biased with our critical care training program as I'm a product of it from 1990. So I can vouch it's a very good program. And I know the costs of training were asked in the March Board of Supervisors meeting. And so if you look, it does cost about $30,000. And these are just direct costs. When we met with RMPA, there are a lot of indirect costs. They're hard to put a figure to, but RMPA leadership really wanted to make sure that I addressed that we can't just look at the direct costs, because when new grads get off orientation, they can't take as much of a load. Their time management skills are still developing. They can't take as quite as high of acuity level. So again, the costs do vary depending on experience and clinical setting. Our future plan is, again, to continue to work collaboratively with RNPA. We really need them at the table. It's we. And we did find we do have a deficit that we don't really have a formalized recruitment and retention committee. So we are going to be forming one. And the membership absolutely has to have frontline staff. It's so important that we have their voice at the table of what's working and what's not working, also including nurse recruitment, of course, nursing leadership, and our clinical educators. We are also going to be doing focus groups for our new hires. Nurses that are in the first 6 months to a year, again, really sitting down with them and how can we better our program? We've reinstituted the unit shared leadership for inpatient. All of them are up and running. And as far as shared leadership, it's so important as a CNO that nurses at the bedside have input into decisions about their practice, their work environment, and it really increases nurse engagement. We've also been successful with having some house-wide or division-wide cross-functional teams that are working in critical care, med-surg, and maternal child health they're working on issues that affect all aspects in their division. We're going to be instituting the hospital-wide shared leadership, so nurses will have an ability to participate in hospital activities and not just their unit activities. Again, we have made a really mindful effort to work on positive employee relations, and Nursing Administration launched a kindness campaign in September to really set the tone for a respectful, kind environment. Of course, being kind to our patients, but people need to be kind to each other. It's kind of taken off. We have to keep it on the forefront of all of our communication. Employee wellness is a hot topic, and I know Paul has had lots of conversations with executive leadership of how important it is to invest in our employees and employee well-being, and I know that's a priority for the county. But we really want to have a subgroup out of the nursing recruitment that's really looking at a nursing well-being specific to nursing. We've launched a Code Lavender, which is a structure to support nurses after a traumatic event, whether it's a code situation or a child death, that they can really have support immediately. And I'm really happy to say that we piloted a mentoring program in the pediatric intensive care and the pediatric unit, which has been very successful, and we're rolling it out to critical care. So our 52 either new to critical care or new grads into critical care that we just hired are going to be our test group to really look at retention and how having a formalized mentor really helps with retention. And lastly, with also the voice of RMPA, we've requested additional FTEs for our float pool, which again, the resources will be to help with additional rapid response nurses, with creating a float pool for ICU, step down, and med-surg, and also vascular access, so we can put the resources to the frontline staff and better support them. I know that was a lot, so I'd like to take any questions or clarify anything.
Thank you, Jill. I think what we'll do now is hear from the public, from RNPA, and then have a discussion at that point. I'll read the names of the folks who filled out a card and read them in the order that I was given them. And if you want to then just line up, Mike Benapayo, Alan Camara, Linda Hurley, Letitia Cordona, Melissa Truesdell, Fernando Rockchild, Debbie, I think it's Chana, and then Shannon Ruth. I know that you filled out a card and you attached several items, memos, and I don't know if, Shannon, where are you? If you wanted to speak or you just wanted to make sure that the board had received it. Yes, I know that I received it this morning. I'm assuming Supervisor Smidian may or may not have. But you're welcome to my copy for the moment. All right, please come forward. Mike, are you going to start off?
Yes, sir.
And you'll each have 2 minutes.
Hello, good morning, Health and Hospital Committee members. My name is Michael Benapayo. I'm a member of the Board of Directors for the Registered Nurses Professional Association. I've been working at the Santa Clara Valley Health and Hospital System since 1999. I've worked in several units. Amongst them are in the ICUs, emergency department, also in the clinics. I could personally tell you that having experienced registered nurses are crucial in saving lives. Majority of the patients getting services at the county are not your typical patients. These are patients with chronic health issues as well as severe psychosocial issues. Having experienced nurses are important to patient care as well as providing resource to our newer nurses. Today I walk the floors of our hospital in the different units, and I do not recognize many of the young staff members. I have friends that are moving to the clinics and elsewhere because they are afraid of losing their nursing license as a result of unsafe staffing mixes on the floors. Santa Clara Valley and Health Hospital System is unable to attract experienced nurses. As you could read from the recruitment and retention report, we are unable to hire experienced nurses to replenish the experienced nurses we have lost. Furthermore, we keep hiring new nurses as extra help, but lose them to other hospitals for more competitive wages. The report will incorrectly tell you that we are losing nurses because of, we're not losing nurses because of low wages, but we are losing them because of that. I work as a nurse at the hospital, and I talk to the nurses every day. So please do something to stop the revolving door. Thank you.
Good morning, Health and Hospital Committee. My name is Alan Kamara, and I work in the ED. I'm a bedside nurse, and I'm a member of the RMP as well. My effort today is here specifically to thank Dr. Ken Hager, Dr. Smith, Mr. Paul Lorenz, and Jill, and your staff and your team. I want to encourage you guys to push for our effort, our collaborative effort, to make sure all these numbers that are up here make sense at the end of the day. When you go around speaking to nurses, our nurses feel overworked every day training new nurses, and 6 months later, these nurses are leaving us. And when you reach out, these nurses want us to come here and advocate on their behalf and push that you help get a system where we have a retention plan. Yes, we've worked with the hospital administration, and we've tried, but we've come a long way from our previous report. But this time, we feel like there are certain areas that we can address, and that area is how can we retain the nurses that when we hire them, how can we retain them? What are we doing? What are the efforts? Yes, we've made plans, but how can we push forward to make sure those efforts are sustainable? And how can we approach and attract clean nurse threes that are the experienced nurses from outside to come? Yes, it's very competitive, but what is Santa Clara doing to make sure these nurses come to us and the state? And we're using the social media. Social media, sometimes it's not as effective as we think they are, because some people might approach your site and they are not just there, they're just hit, and there's no way to find out whether these are nurses or not. So we want to thank you for your effort, and we encourage that you push administration to work with RMPA so we can stop the revolving door. Thank you.
Good morning. My name's Linda Hurley. I've been working at the hospital since 2007, and I've worked in about 4 different units, including teaching HealthLink for a year. When I first came to work, there was a sense of fairness here, and the healthcare worker was valued. The job was hard and also stressful as a critical care RN then as it is now, but there was an ability to approach management with the expectation that your voice would be heard and that there would be an honest attempt at finding an equitable solution to a problem. I don't find that today to be as true. When a thorough, accurate, and even conservative study is presented to you by a qualified and responsible individual showing you a significant and widening disparity of wages between the VMC nurse and the RNs from virtually every other hospital that surrounds this area, the response is to have the labor relations pull a wage figure from jobs.com and use that as an accurate figure to refute the entire Brenner survey and have you embrace that figure. When I was hired, I was informed by my manager, Donette Kelton, that it cost $60,000 to train me and that it would take 2 years to recoup that cost. The report that you're seeing, and Jill has spoken to this, so I would back off to some degree. I didn't know that she would include some extra things, but there is a report by AFSCME that was put out in May of 2017, which gives, I think, a much more accurate picture of what it costs to train your nurses across the board. And is it likely training costs have gone down since the time I was hired in 2007? I don't think so. We live in a reportedly 1 to 3 of the most expensive places in the United States, making what is now considered a low-income status. I'm going to cut this short because I'm losing part of my talk, but we need to be able to come to the table expecting both parties are working together in good faith and a fair and equitable resolution for both being the goal. Thank you.
Thank you.
Good morning, close to good afternoon, gentlemen, madams. My name is Leticia Cardona. My title is RN, Major, Air Force, retired. I've worked for county for about 30 years, and I'd like to thank the county because of how it's set up. I was able to have both careers. I float through the nursing office as a med-surg float. I've also done nursing supervisor. I also do what they call ADT, admit, discharge, transfer. Being that I'm all over the place, I have been able to witness what my colleagues have said. We're very short-staffed in many units. We have very new people. They leave after 6 to 7 months, although the statistics that were shown might not reflect it, but nurses leave after getting experience. They go to hospitals where they get paid better, and all they need is 6 to 7 months to get hired. It's a revolving door. We continue to train people. And then we don't really have a mentoring program, and to have one just for ICU doesn't quite cut it because the bulk of the patients are in med-surg. The bulk of the patients that we get are not what the outside hospitals get. We have a lot of violence in the workforce by patients who curse and throw things at us, and yet we're supposed to just be quiet. Nurses have gotten hurt on the floors from violent patients. We really need to retain our nurses, not just by offering them extra help. I never knew how badly we were paid until my daughter, who is a nurse as well, went to an outside hospital, and basically she's only been 2 years as a nurse and gets paid about $15 less than I do, and yet I've been a nurse for a very long time. That shows that we're really underpaid. And it's not just about the pay, but it's about making the environment good. It's about being able to be open without management penalizing you or criticizing you for being a troublemaker when you're trying to make things better. So please listen to everyone, and hopefully we'll get better nursing staffing ratios and coded positions. Thank you.
Hi, good morning. My name is Melissa Truesdale, and I'm what Jill would refer to as a frontline nurse. So much, in fact, I worked last night, and this is an important topic to me to be here today. I've been at Valley Medical Center since 1999, and personally involved in the training of a great many nurses. I started as a coded employee. When I did start, extra help was pretty much a non-existent term. VMC is going to be the safety net for the community. We need to have more coded core staff, because what I'm seeing is a failure of core staff. We hire these new extra helps on our floor only to watch them leave with a handful of our core staff that still remains, because they are coded in place. They offer codes, they feel valued, and they stay. We need to encourage nurses to stay. And how do we do that? We offer more codes, because we do know that, experience really, would you rather have an inexperienced nurse putting a catheter in you or an experienced nurse? Experience speaks to a lot. If VMC is to be the safety net for the community, our core staff, our CLIN 3s, need to be the safety net for the hospital. And I'm not a math whiz, but I mean, $50,000 to train a nurse is a lot of money, and that's not cost effective. We need to grow our nurses who then feel valued, to want to stay and be part of our core staff. So we have nurses who are capable of taking care of these sick patients, know our policies, and can promote safety. And that's my solution to retention, is to offer more codes to nurses. Thank you.
Thank you.
Good morning, everyone. My name is Fernando Rockchild. I am a registered nurse at Valley Medical Emergency Department. I've been at Valley for the last 20 years, 18 of them in the ED. When I began working in the Valley Medical Emergency Room, there were many experienced nurses that mentored me. Today, there are many new nurses, or the many new nurses that come in are not offered that same experience. VMC is a very busy emergency room with wait times of 10 plus hours, and sometimes we have 30 to 40 patients deep waiting in the waiting room, waiting for a doctor to see them. This is very alarming, because our patients are the sickest of the sick in the county. As a registered nurse working in the Valley Medical Emergency Room, I make life and death decisions. As a triage nurse, I am responsible for recognizing patients that exhibit signs of stroke, asthmatic attacks, cardiac conditions, diabetic crisis, and those are just to mention a few. I can testify this is possible based on my years of experience. I am really troubled by the fact that there are too many new nurses at one time coming into the emergency department. This poses a potential crisis in the making, because aside from monitoring the patient, we as the mentors have to oversee our new nurses who needs that continued support. You may think that, yes, this is my job, and it is, but it is also my job to be a patient advocate. And I am here to tell you that we do not have enough experienced nurses in the Santa Clara Valley Health and Hospital System. Sometimes to appreciate an experience, we need to personalize it. What if you or one of your loved ones were involved in a traumatic event, and they would have to come to a level 1 trauma center such as VMC? You want and expect them to have the best care possible. Experience delivers that care. I believe nurses love to work at VMC, especially the new ones, since we have an excellent critical care program. Our mentors don't eat our young. We want them to succeed. Recruitment is not lacking. Retention is lacking. And the linchpin that tie those two together is equitable pay. So I would encourage you to give our nurses equitable pay and stop the revolving door. Thank you.
Thank you.
Hello, good morning. Good morning, everybody in the Health and Hospital Committee. First off, I want to thank you, Supervisor Yeager, for directing Nursing and Administration to work collaboratively with RNPA in addressing the recruitment and retention issue that we're currently facing in the Santa Clara Valley Health and Hospital System. We met several times with Nursing Administration in trying to address the recruitment and retention we are currently facing. I am happy to hear that there will be more nursing codes for our nurses, and in particular our extra help who deserve to have those codes. However, I cannot agree with the hospital administration's current method of the clinical nurse salary and placement guidelines because we are not addressing the heart of the matter, which are the wages. If we do not jointly acknowledge this as a core issue, we will continue to lose our nurses. We are not commensurate to our major competitors such as Stanford, Kaiser, O'Connor, and Regional. We're going to continue to lose our nurses. A year has passed, and I'm addressing the same problem. In fact, I was addressing it at the Board of Supervisors. As a level 1 trauma center, we should have a balanced nurse skill mix throughout the hospital, clinics, custodial care, and mental health, but we do not. Santa Clara County Health and Hospital System does not have a solid plan on how they will retain the nurses they hire. They continue to use the same ineffective plan that has proven to fail year after year. In order to promote safe patient care, Santa Clara County Valley Health and Hospital System need a balanced skill mix of clinical nurse 1s, clinical nurse 2, and clinical nurse 3. I'm asking you to address the non-competitive wages for nurses throughout Santa Clara Valley Health and Hospital System. If this does not occur, we will continue to be a training ground for the other hospitals. Thank you.
Thank you very much. Paul, why don't we turn it back to you? I know that our speakers raised any number of good points that you might want to address and maybe also comment about ways we could move forward. I know that there is the creation of the Standing Recruitment and Retention Committee. In the letter that we got from RNPA, they include a comment in their report recommending that this committee be a collaborative partnership with RNPA with agreed upon guidelines and process for the work of the committee and timeframes for implementing committee recommendations, including elevation of committee recommendations to specific organizational levels within the county that have the authority to recommend or implement organizational and financial decisions with regard to recruitment and retention. And I think that was a theme that was certainly mentioned in many of the comments that we heard.
Thank you, Supervisor Yeager. First of all, I do want to thank RNPA and the individual nurses that have come up and spoken eloquently about the importance of recruitment and retention of nurses, in particular our interest to retain qualified, experienced nurses at Valley Medical Center. I think, as Joe's pointed out, we've been very fortunate to have open conversations and dialogue with RNPA, and I think that's critical going forward. This is a multifaceted, complex problem and challenge for all hospitals. I think at Valley Medical Center, we stand above the others in terms of our opportunities to recruit and retain nurses that share a commitment in service to our population, meaning the entire community of Santa Clara County. We will continue to look at ways to improve the working environment for our nurses because we believe that to be a critical factor in a nurse's decision to remain employed at Valley Medical Center. The effort to seek and receive input from our nurses, as Jill has outlined in her plan, will be critical for us to actually understand from their perspective what we can do better. And that's a big part of the plan going forward from a nursing retention standpoint. We've heard a little bit about the importance of compensation. There's no doubt that compensation plays into a nurse's decision to stay with Valley Medical Center. We have been working very closely with the County Executive's Office and Labor Relations to look at that, and we will continue to do so. But that's one factor out of many, from my perspective, to get to the point in which we feel comfortable that we're doing the best we can around the recruitment and retention of nurses. One of the things that I will point out, and which is unique to Valley, is that we train a lot of nurses. You can see by the number of new applicants that apply at Valley, new nurses that apply at Valley Medical Center, it's a significant number. And many of our nurses that train and are educated at Valley eventually become employed at Valley as a per diem, then on to as a coded position. Not everyone will stay at Valley because they have different interests from a career standpoint. But if you look at the promotional opportunities for nurses throughout the system, nurses do move through the system to other departments, from medical surgical to critical care to ambulatory services, including specialty. Nurses here at Valley also are given the first opportunity to move within the system and to be promoted within the ranks of nursing clinical steps, including the Clin Nurse 3s. And what I mean by that is that when we have open positions for experienced nurses, such as Clin Nurse 2s or 3s, internally our nurses promote up within the ranks. And then what happens is that then we open it up to outside potential candidates. And what we have at Valley, unfortunately, is that many of those positions that are open to the general population of nurses interested in working at Valley are usually evenings and weekends. So that does present a challenge in terms of us bringing in experienced nurses. But when we do have those opportunities, and as Jill's pointed out, both in the OR, critical care, as well as the ED, we are able and have been able to hire experienced nurses with 20-plus years of experience, if not more. So it is a balancing act. I think it goes back to a collaborative, ongoing discussion about what we can do operationally to improve the work environment and continue to work with, of course, labor relations in the county exec's office on looking at the market and compensation. And I also would also say this to the board, to this committee, and to the county executive. We have been very fortunate to have your support. And if you look at the number of nurses that we've added to the ranks over the past 5 years, it is significant. We have a staffing ratio in terms of coded to extra help and per diem that is favorable. Although it does present a challenge when we fluctuate in terms of our census, in terms of making sure that we are, making sure that nurses have work to do, because certain units, the nursing ratios are met, but at the same time, our census fluctuates to a large degree. So I think with the support of the county executive and the board, we've been able to add a lot of coded positions to the workforce, and I'm very pleased with that support, and I hope RMPA is pleased with that support as well.
Yeah, I guess I'm trying to figure out, I mean, there's still a lot of issues that need to be worked out, and I appreciate what you said, Paul, and I know there's the Committee on Recruitment and Retention, as well as one, I guess, review and recommend next steps toward implementing more competitive compensation for clinical nurses. I guess I'm trying to figure out, do we know how our compensation compares to our competitors? Are we looking at that type of data to sort of see where we are, and trying to also get more of a sense of people who are leaving to go elsewhere because of higher salaries? I'm just trying to get more of a sense of what I think many of the nurses sort of might know anecdotally in conversations with other nurses, and what kind of information we could actually get to sort of show whether that's actually the case, or what it is that we might need to do to work on compensation so we can increase retention.
We have received a number of different reports and information relative to the market, particularly in this area. I think what we probably need to do and continue to do is work with the county exec's office and labor relations to make sure the information that we have is current and accurate relative to any further decisions. So at this point, I probably defer to the county exec's office relative to this issue of compensation.
Well done.
He's getting better at that. Huh? Yeah, county labor relations has done surveys. There's always a number of complexities involved in doing surveys. One is particular work assignments, the way that different hospitals use nurses in different ways, change their assignments around, have more floating, less floating, comparisons of extra help to ICU or specialty centers. And then we also have a very significant and high benefit costs that virtually nobody else has. So, we consider these all the time when we're going into negotiations, and I'd prefer not to negotiate from the dais, but we will certainly report back to the board in closed session any recommendations that we have for changing compensation. I will point out to the committee that we're adding, if you approve the recommended budget, over 30 new coded positions, and we have more coming with the revision of the recommended budget, and also you'll be seeing in the summer more coming for the so-called ADTs and resource nurses, which I've asked Jill and Paul to look at and give us some proposals for numbers. One of the significant problems that we have, which is actually sort of a good problem, but certainly one we want to fix, is that with the building and occupancy of the Sobrato Pavilion, we now have 2 buildings, obviously, and so the resource nurses and admission discharge nurses really are having a hard time going back and forth between the 2 buildings, and we already are understaffed with those particular groups of nurses, so we're going to add more to that to help with that function. That will help significantly with the work environment, because right now what's going on is not what was designed from the admission discharge nurses and resource nurses program. It was supposed to be that when nurses on the floor needed additional help, they could call for additional help and have the additional help show up and be there and available for a while. With a smaller group of resource nurses, they don't have the ability or time to put effort into every unit and every need. We're going to expand that at least by 8 positions, probably more. So we're trying to address the multiple facets, and I'll just point out to the committee also that every hospital in the nation has major problems with solving all of these problems at the same time, because the reality of hospitals is that patients come to hospitals for nursing care, not physician care. They go to clinics for physician care. So the nurses are the most important resource we have in the hospital, and they're also, very hardworking and put under a lot of pressure. So trying to deal with all those problems is always challenging.
All right, thank you, Dr. Smith. So, Paul, I know that RNPA, as I had read, one of the recommendations is the creation of the Standing Recruitment and Retention Committee. Has that been established or is about to be established? Will be established? I'm not sure which verb tense to use here.
Well, I think we're going to formalize that. At this point in time, RNPA and nursing do meet on a regular basis. They're currently looking at, for example, the in-placement of nurses within the salary range that's available. I think that's critically important, so we standardize it to make sure that we're fair across all the different units, both inpatient and outpatient, so that we can actually offer competitive salaries given our current pay range. So they've been working on a number of different important issues, and I think they'll continue to do that. But I think at this point in time, we're going to formalize it on a regular basis and be very clear of who the participants will be.
Good. I guess I wanted to end this with a direct action that we're going to go forward with so we can resolve these issues. I think often we're talking past each other, and I think everybody needs to sit down in the same room and present the information that each sort of side has so we can come up with at least a baseline on many of these issues as far as where we are, and then leave it up to the board then to make whatever decisions we might need to do as far as compensation and other issues. And then, of course, their other recommendation, which I had mentioned, is review and recommend next steps toward implementing more competitive compensation for clinical nurses, but I assume that could be part of that committee discussion as well.
Yes.
Supervisor Simitian?
More just a couple of observations or reflections. 2 years from now or 5 years from now, as this committee convenes with somewhat different membership, I don't anticipate that this problem will have been solved, quote unquote. And I say that in part because I think, particularly to those of you who are professionals in the field, it's abundantly clear that this is not a Santa Clara County specific challenge, nor is it a Valley specific challenge or a regionally specific challenge or a state challenge or a national challenge. This is, a global challenge that happens to be particularly acute in some locations. I can remember as the newly installed chair of the Budget Subcommittee on Education Finance in the year 2001, trying to move some money towards training for nurses here in California, and Governor Gray Davis at the time exercising the ability to line item those dollars out of the budget because he correctly foresaw a dip in the economy and said that the training programs weren't going to be sustainable. And I remember, in the back and forth with the governor's office at the time saying, well, I understand your concerns about the funding for the programs, but the decisions we're making in 2001 about training, or in this case, cutting the training, are going to have long-term implications in terms of the nursing shortage in California. And here I sit 17 years later living with the consequences of those decisions and myriad other decisions that were made in other venues that left us here. But, given the funds that have been devoted or not devoted to training the next generations of nurses, I can't say that we should be surprised, and as I said, given the fact that this is an issue that goes well beyond our boundaries, I can't say we should be surprised. I did not mean to be negative when I said I didn't think we were going to have problem solved in 2 or 5 years. I'm trying to be realistic, and actually, Supervisor Yeager, where I was headed with that comment is to suggest that there isn't a magic quick fix on this one, that there's an array of issues that have been described, and whether you want to call it a half dozen or a dozen items that'll be discussed in the committee, ultimately I think we're going to have to be doing our very level best on a half dozen or a dozen different fronts to get there. So I wish there were some reason to think that when you all sit down we can say, well, if we do this one thing or we do these two things, it'll all be good. I'm not optimistic that that's the case. I think it's going to have to be and I know it's tough organizationally to sustain an effort on a half dozen or a dozen fronts, particularly when it doesn't always seem or isn't readily apparent that, hot damn, we've got it fixed, because I don't think you're going to get that. But I sort of want to underscore the fact that I think that's going to be important, both in terms of the range of solutions that you're looking at and the longer term commitment that we're going to have to make, even though we may not see the kind of immediate or dramatic improvement we want. And with that, I will let it go. Thank you.
Thank you. Paul, anything else in your report, or have we covered it all?
That is it for my report.
All right, then we'll take a motion to accept that report. move over to item number 9, receive report from Valley Health Plan relating to improving healthcare effectiveness, data and information set scores, including breast cancer screening rates.
Thank you, Supervisor Yeager and Supervisor Samidian. I'll offer a few items from the report as highlights. First, I'll review many of the initiatives that Valley Health Plan is taking around the goal of improving breast cancer screening rates. They really fall into several areas. One is our Pay for Performance program for primary care physicians, which is being rolled out and strengthened on a quarterly basis. And in addition to a direct metric around breast cancer screening, we also include a metric on primary care utilization rates, which we increasingly believe to be an important factor, and I'll say more about that later. We also, through a tool called Care Gap Finder, push out information to our provider network, identifying particular patients of theirs that are assigned to their clinics that are not receiving scheduled breast cancer screening as they should be. We also have direct outreach to members, both telephonically and through direct mail, and are even offering some modest gift incentives in order to complete the diagnostic protocols, subject to county policies around that, of course. So that all leads us to then how well are all these initiatives working? Are we starting to see an impact from them? And unfortunately, the answer is either no or not yet. Our HEDIS measures around breast cancer screening continue to hover right around the national median for health plans. So on the one hand, of course, that's better than the alternative of underperforming, but that's not the level that we're aspiring to. We're not ready yet to abandon any of these initiatives because intuitively they seem like they would be useful and would make sense. It may simply be that it will require more lag time before we start to move the needle on the outcome metrics. But meanwhile, there are a couple of other more subjective kinds of information that we're looking at that are leading us to consider some additional measures. One is, I believe the committee had asked at an earlier date how we compare to Kaiser in this regard. And we're still trying to get our hands on hard data around that. We're not privy, of course, to Kaiser's numbers as a competitor. But anecdotally, we do believe that Kaiser's numbers are actually significantly better than what we're experiencing. Another thing that we've looked at is in terms of in comparing notes with Valley Medical Center on their HEDIS measures. We've noticed that their HEDIS measures around breast cancer screening are much stronger than what we experience on the health plan side. Now, on the surface, a lot of that can just be explained away because providers and health plans look at the numbers a little bit differently. On the provider side, the ratio in the denominator is actively engaged patients, patients that have actually been seen several times in the last several years. Whereas on the health plan side, we look at the entire enrolled population. But when we think about that a little bit more deeply, it begs the question, well, maybe the results are better at VMC with that population simply because of the high level of engagement with the delivery system. So perhaps we could look at more of a root cause and encourage our members much more strongly to become more engaged with the delivery system in general, and perhaps primary care in particular. So How to address that will be a little bit complicated and brings up issues around privacy and how intrusive we should be as a health plan, but we are definitely starting the thought process in that regard, and we'll be exploring some additional actions over time. With that, I defer to any questions.
Thank you, Supervisor Smitty.
Thank you. I appreciate the update, appreciate the candor on the lack of improvement in the numbers thus far. Could you be a little more explicit about sort of how we're going to assess what it takes to move the needle on this? Are we at a wait and see period a little bit here on some of this?
We're in a little bit of a wait and see period, but we're going to start exploring the additional direction of looking at primary care engagement in general, and perhaps comparing, taking a little more granular view of our data and slicing it a little bit more finely to test whether, in fact, it is non-engagement with primary care heavily correlated. Intuitively, one might think it would be, but we want to explore that a little bit further, and then perhaps try to come up with some initiatives around primary care utilization in general, because we do observe sort of a supporting piece of evidence that our primary care utilization rates are lower than most health plans would expect.
So, understanding that this conversation is largely anecdotal rather than data-driven, could it be as simple as if people don't go to the doctor, they don't get reminded, oh, by the way, you should have a screening? I mean, are we at that level of?
It very well could be that simple,
okay.
But we need to analyze it a little further to test that.
And I want to test my memory on this subject, but part of the reason that I've expressed an interest in this subject is my recollection is that this is not only, that screening is not only important in a sound practice in terms of healthcare, but that from a financial standpoint, we're in a situation where the cost of, let me flip it, that early detection saves us a significant amount in terms of dollar cost later on in terms of healthcare costs, yes?
Yes, that is absolutely correct.
Okay, so I guess, whenever we can be pursuing paths, to Supervisor Yeager's earlier comments about public health, whenever we can be pursuing a path that makes good sense from a healthcare standpoint, but that also has the potential for significant healthcare cost savings, that's a path we want to be on. So thank you, and just thank you, Mr. Chairman. I'm happy to move that we receive the report, but hope we stay on this and figure it out.
Agreed. Thank you, and so we'll move that report forward to the board. We move to item number 10, receive report from Public Health Department relating to the state of sexually transmitted infections and related complications.
Good morning. I want to introduce Dr. Sarah Lewis, who will be providing the report. Sarah Lewis is our HIV STD controller. She's been with our department less than 2 years, and she's really been able to drive a number of changes that I think allow us to better prevent and control what you will see are rising rates of STDs in our county. So, Sarah.
Great, thank you, and I'll ask you to advance the slides. Thank you, Supervisor Smitty and Supervisor Yeager, for your time. So I'll share with you what we think we understand about the problem and then what we already have in place to begin to respond to it. So fortunately, what I'm not here to talk about is HIV today, because as you see, looking all the way back to the beginning of the HIV epidemic, the powerful biomedical interventions we have that prolong life with HIV and prevent transmission have decreased the rates that we've seen across California, across Santa Clara County, and increased survival. And next slide, that's true here in Santa Clara County as well, that we have roughly low, stable rates of new HIV infection overall for males and for females, and really our insights of getting to 0 new infections. But unfortunately, that's not the case with other STDs. So if we go forward to try to understand what kinds of things are big enough powers to shape big STD trends, this looks all the way back to the beginning of tracking syphilis across California. And we saw that, for example, biomedical interventions like with HIV and the discovery of antibiotics in the 40s have the power to dramatically drop rates of STDs. But other big trends like the crack epidemic in the 80s, like the unfortunate illness and death of people living with HIV in the late 80s and early 90s, which took them out of social networks, these big social and demographic forces have the power to make big change. And we appear to be in one of those times of big change right now. So if you zoom in on the 90s forward, next slide please, across California, you'll see that we're in one of these times of increasing rates of STDs across California for chlamydia and gonorrhea and syphilis. Some starting as far back as 1995 when chlamydia traits were heading in the wrong direction, and then since the mid-2000s, that's true for gonorrhea and syphilis. Zooming in more closely and looking at Santa Clara County, that's true for us here as well. So this shows chlamydia rates. The red line is among females and blue among males. And we're seeing rising rates, certainly since 2010 and actually farther back for this disease. This is true for gonorrhea as well, with an even more concerning slope and even faster rise of gonorrhea, such that we've actually seen a quadrupling of rates since 2010. And then if you move on to syphilis, the most concerning is how fast rates of syphilis are rising in our community and across California and across the U.S. While we have more cases overall among men, and that's something we're addressing specifically, we see the rates rising the fastest among women, with 10 times the rates of syphilis in women last year as we had in 2010. And next slide, part of why we are so concerned about syphilis is a couple of factors here. The first is that like chlamydia and gonorrhea, it's often asymptomatic. So people may have it and be passing it to their partners without knowing they're sick, and unless they get tested, there's no way to know and get the treatment they need. Secondly, in any adolescent or adult who acquires syphilis, there is risk of serious side effects. Specifically, blindness and deafness and stroke can occur in adults who acquire syphilis. And then I think of greatest immediate concern is that anyone who's pregnant and acquires a syphilis infection during pregnancy has the risk of passing that infection through the placenta to the fetus. And this can be life-threatening, can cause miscarriage or stillbirth or neonatal death, or if the infant survives, can cause lifelong disability like blindness or bony abnormalities. And this is what we refer to as congenital syphilis. Now, good news here is that all of these infections we've talked about, chlamydia, gonorrhea, and syphilis, are relatively very easy to cure with antibiotics. And giving antibiotics to a pregnant person with syphilis can avert 98% or more of congenital syphilis cases. And then finally, giving antibiotics to an infant born with congenital syphilis can still dramatically reduce the risk of lifelong complications and reverse many of the problems. So if we go to the next slide, that same trend that we've been seeing across California since about 2000, 2005 of rising rates in syphilis among women and rising rates in congenital syphilis are now hitting Santa Clara County. And so here we've had about an average of 1 congenital syphilis case a year for decades, and we had 7 cases last year. And while 7 feels like a low number, we look sort of like Fresno and Merced and San Joaquin did a few years ago, and they're now seeing 20, 50, 100 cases of congenital syphilis. If we go to the next slide, we see what Santa Clara looks like on a heat map compared to some of the surrounding counties that are even harder hit. So on the left, you see the rates of syphilis among females of childbearing age, and you see that while there's not an official cutoff for what is a high morbidity jurisdiction, we are above what some experts would consider high morbidity and have been for almost 2 years now. And then looking at the right at the map of congenital syphilis cases, we see this matches where we have high rates of syphilis among females. And while we're not in the bright red like the Central Valley and Southern California, we do look like we may be headed in that direction. So if we go to the next slide, I think the big question is why? Why are we seeing these changes? Why are we seeing them across the country and in California, and why here at home? And I think that's probably very complicated. There are probably elements we don't understand as to why, but some of the things I think are in play are the following. First, I think STDs don't respect county lines, and so when there are rising rates across California, no matter how perfect our systems are here, there are going to be rising rates in Santa Clara that we have to be ready to respond to. The next is that some likely social changes in the way sexual networks are formed or relationships are started, including dating apps and similar changes, may affect some of these trends of shifting STDs and certainly affect the way we can use tools in public health like partner tracing, where typically it's been a major tool of ours to ask someone who their sexual partners are once they're diagnosed and treat those folks. And folks who have widespread geographically or don't know the names of their contacts make that more difficult to do.
Excuse me, through the
Please.
chair. The potential relevance of so-called dating or social networking sites on this issue has been somewhat discussed in the popular press. Do we have real data on this, or is it largely anecdotal?
It is mostly anecdotal. What we have data on is that the ability to know the names of contacts of people with syphilis and gonorrhea and find those people and get them treated has decreased steadily, and this appears to map with people who use dating apps. So that there's definitely information that tool of partner tracing isn't as powerful a tool or as sufficient a tool as it used to be.
And the partner tracing, if I remember my public health history, was really sort of pioneered back in the mid to late 20th century with public health efforts at the time, yes?
That's right, and it's a core part of how we respond to any epidemic. With a measles case, we find everyone they may have been in contact with who is unvaccinated. And so similarly with a syphilis or gonorrhea case, we ask who their sexual partners were and try to find those folks. But again, people are both more and more reticent to tell us who those partners are and less able to if they met them anonymously.
Thank you.
Sure. So to continue just on a couple of other factors I think are in play, I think like many public health concerns, we see multiple social factors in play, especially drug use and especially methamphetamine use. And you'll see when we look specifically at the congenital syphilis cases that that's a really strong factor. And then I think that relates also to use of sex for survival, for access to housing or food or safety or drugs in the case of drug use is another element at play. And then finally, there have been national experts who felt that reduced access to STD care in general is likely potentially another major factor for the rising rates we're seeing nationally. So just to give a little more, I'm sorry, I've got these. So to think about what the next steps are for Santa Clara County, I think one step that is key to what public health does is it's really our job to understand the epidemic because we have access to data that other folks don't have access to use those tools in our research capacity to understand questions like what you pose, Supervisor, to really know where we can target our interventions and then what's working. To also look at what collaborations we already have in place and what tools we're already using that are effective to scale those wherever we can in the most value-based way. To think about new partnerships for where people at higher risk might be available for testing, but it's not standard of care, so that we can expand testing in those settings. And then finally, are there any big changes? And I'll talk about enhancing syphilis screening in pregnancy in particular in that respect. So, sorry, you can advance to add the pictures in. One more, please. So the bulk of what I'm presenting to you now comes to us because Title 17 of the California Code of Regulations requires laboratories and providers to tell us about any of these diseases they detect and diagnose. And then it's our team's responsibility to complete that reporting and then in many cases investigate the individual to help make sure they've been treated, that they have other preventive tools at hand, and that their partners get tested and treated. And so in order to make this work, we need to keep this system running and have it run as smoothly as possible with data systems that are bi-directional, as automated as possible, and so that my investigators don't spend their time waiting for a fax to come in, but instead access information in a 21st century way. Next slide, please. Additionally, we're digging in for the cases that we do know about and in a more research-focused capacity trying to understand them. Now, the cases we learn about are always a subset of what's really out there, but these 7 cases that we know resulted in congenital syphilis last year, we find a couple of things that are striking. One is that every single one of those cases had a known history of methamphetamine use. And so thinking about substance use and how we can connect that to sexual health care is one of my key goals. Next is that a majority had a prior history of incarceration, and for those we know about their partners, a majority of the partners had prior incarceration. More than half had a history of unstable housing. Nearly half had a history of mental health care. Please.
On the history of incarceration, you established that there's a correlation.
Right.
Did you also establish causality, or do we just know that there's a correlation?
Just a correlation. This is just a risk factor. And so, especially because these are all heterosexual individuals, there's no concern of, for example, in custody transmission in these cases, or nothing that's raised that concern. More that may be an opportunity for intervention if we think about improving the access to screening we have in incarcerated folks.
Thank you. Thank you, Mr. Chairman.
And then one endorsed specifically that there was exchange of sex for money or needed goods, but given the amount of methamphetamine use and unstable housing, my concern is that there is more exchange sex, more survival sex happening in this population. Another on the right, the graph shows us, unfortunately, that nearly 3/4 of this group had no prenatal care prior to delivery. And so when we did investigate the cases who did, the prenatal care provided was absolutely in line with recommended care, but we know that that's not going to be enough to really capture this population who presents late to prenatal care in pregnancy in order to avert these cases. And then while not all of them delivered at VMC, all of them at some point touch the VHC system, which suggests that VHC may have a power greater than some of the other hospitals in the county to reach people at greatest risk for syphilis in particular and for other STDs, and offer intervention in unusual places beyond the usual primary care screening where we can also improve our care. Next, please. In addition to other things that we have in place and that we know work, the Getting to Zero group already has an STD and HIV guideline-based testing action team that is right now shifting their focus, to look more at what kinds of STD screening is already happening in primary care settings, and then how can we scale that, and making sure that STD messages are integrated into everything we're doing with respect to Getting to Zero. In addition, somewhat in that setting, we already have a public health detailing campaign where health educators go to teach providers about best sexual health practices, currently focused on HIV prevention, but working to integrate sexual health messages. Additionally, we talked about contact tracing and partner services and scaling that with a specific focus on those at highest risk. And then we know that HIV pre-exposure prophylaxis is actually a really powerful tool for STD prevention. If we go to the next slide, there's a couple of studies already coming out of San Francisco showing that people engaged in PrEP care are at very high risk for STDs, but are more likely than their non-PrEP receiving counterparts to get timely testing and timely treatment and have lower risk of transmitting to their partners. And this was a mathematical modeling study showing that if we can get 40% of people who need PrEP access to it, that engagement in care is likely to reduce the overall gonorrhea and chlamydia rates by about 40% across that population as a whole. Next, please. And then in terms of new collaborations and next big steps, we're already in progress strengthening our relationships within the public health department and with public health nursing groups that already face pregnant clients in particular, or other groups at risk. We're working closely with custody health to overcome some of the barriers there are to accessing screening in the jail setting, because we do think that that is a risk factor for increased risk of other STDs. We're also working with other hospitals in the county, both with their OB providers and their emergency departments and their behavioral health components and substance use groups to help enhance opportunity for screening in those settings as well. And then finally, I've been working closely with Dr. Byrne in Valley Medical Center's OB department to start a pilot of third trimester rescreening for syphilis for all pregnant patients coming through some of the VHC clinics, because there is a CDC recommendation for areas of high morbidity to consider this routine screening for all pregnant patients. And given the fact that we can often avert just one neonatal ICU stay of 10 days by diagnosing one case early, this is potentially actually even a cost-saving measure, even with the additional screening that we'd be asking for. So the last slide to conclude, we've talked about the rising rates across really all demographic groups, across all bacterial STDs, some of the risk factors for especially congenital syphilis and what that tells us about where we can intervene beyond usual primary care, and that we've already started some of these collaborations across the county and other county resources to try to improve those rates. And I'd be happy to answer any questions anyone has.
Thank you, Dr. Lewis, and it really has been a pleasure working with you since your arrival, and I think you're just doing great work, so thank you very much. I want to mention, particularly to you, Supervisor Smitty, I think we're going to go over our 12 o'clock, maybe about 12:15 or so. I know we have a couple more items that we have to get to, and I certainly want to have a good discussion about this as well. And I don't, I guess in general, and whether it's for you, Dr. Lewis, or Dr. Cody, we've done a lot in this field, but the numbers keep increasing, and so maybe my very broad question is, what more do we need to do immediately? I know we've worked hard to expand the hours and the days of the anonymous STD clinic. I think we need to do more. I know space has been an issue, and hopefully we're resolving that. But because it's such a regional and statewide issue, there isn't really much public attention to this. You would think that is perhaps if it was any other sort of disease, there would be broadcast, go and get tested, be aware of, look for the signs of, and talking to your primary care physician of but there's a silence, and so anyway, I guess I'm sort of curious what our next steps might be, and is anybody sort of working on messaging sort of throughout the region with our other counties to sort of inform people of really what the high numbers are, and that anybody sexually active certainly could be at risk.
Oh, I'm happy to get started. First, to your question about messaging and bringing awareness to the issue. I think one of the struggles has been that some of the typical communications tasks like press releases and news media are reaching an older audience than the people who are most impacted by the diseases. So we are working with our new communications manager at Public Health to make sure that we really are using social media and social marketing to try to reach the youth who are most impacted by the disease. I think another major focus of our work in STD HIV program is to make sure that county schools are in line with the California Healthy Youth Act, which requires public schools to be teaching this material and making sure that the youth, even before they become sexually active and at risk for this, are aware of the most up-to-date science about it and the rising rates themselves. Dr. Cody, would you add anything to that?
Certainly agree with all of your comments. And as far as our system capacity, because we both have a prevention role and a response role, and I think that for our response role, there's two major tracks. One is to ensure that we have capacity for the direct categorical STD services that we provide, because we know that many, even if they have access to primary care, they may not seek sexual health services from primary care. But the other is, and this is more longer range work, to work on stigma issues around sexual health, and to work on education of primary care sites so that they'll provide appropriate screening. So we have to do those in parallel.
Maybe, I don't know if this is for you, Renee, or for Paul, but what role can our clinics and our primary care docs, what can they do to either do more to have a conversation with their patients, or to make the blood test just more routine, something that is just sort of like we're trying to do with HIV testing, just sort of do it automatically. You just and is that another approach? Because there's only so much we can do with the clinic, and it seems like we have to sort of get the whole system more involved in testing.
I would say with confidence that our work with public health is just beginning, and that the collaboration in our interest and Dr. Fong Nguyen and Dr. Winston can speak to this, is very strong. So I think working closely with the experts in terms of implementing programs within our primary care system is on the horizon, frankly. I think the bigger question is, how can we engage the larger provider community in this effort? And I think that's going to be probably part of the plan and part of the effort going forward. And I keep on looking to Dr. Lewis because I see her nodding. So I think, putting a very strong, clear plan together based on the information that we have collectively, I think we can start to see some progress in terms of moving toward what all our interest is to have a greater impact on the community.
Do you see setting up a committee, if you will, of all of the players that are involved? We haven't really even talked about behavioral health and custody health, certainly public health, VMC, the clinics. I mean, there's a lot of players in all of this, and I think it'd be good maybe to at least get everybody together and see which who's doing what and in what area. Certainly not to duplicate area, but certainly to compel all of the other players that they need to do more.
Yes, absolutely. I think based on the discussion today, we do have what we call T2020, which is how do we actually, especially when there's an intersection between public health and the healthcare delivery system, how do we actually learn from very early data, things that are warning signs, things for all of us to learn, and then what are the tools, resources, increasing awareness all the way through the treatment and care that we need to deploy in order to be able to prevent further either spread or in this particular case, obviously, elimination completely. So I think one of the things that will raise it as part of the population health domain under T2020 is to maybe bring those departments and multidisciplinary approach to be able to do the 90-day improvement cycle so that we can begin to really look at the data and then be able to deploy whatever resources or strategies that we need to execute in order to address the issue.
And I know we're going to get to T2020 very shortly here, but Supervisor Smitty?
Just a question, and I'm looking at packet page 102, which may not be very helpful to anyone else. This is the incidence rates from 1990 to 2017, rate per 100,000 population slide. And the question I have is, do we know in most instances, are these numbers, do they represent unique individuals, or are a number of these folks experiencing a recurring incidence?
So we don't know what percentage of these folks are recurring incidents. So this would capture recurring cases. Our definition is that for chlamydia and gonorrhea, any infection that's more than 30 days apart is considered a new infection, and for syphilis that's longer. But there certainly may be some reinfection, but we do think this is affecting a very broad amount of the population. So where you're seeing incidents, that is actually rate per population, the amount of population affected.
Okay, so it's unique individuals, even if they've had 2 or 3 recurring cases.
Yes. So I apologize, I don't know which slide. The incidence, yes, is unique individuals. The
that makes sense.
Numbers, the case numbers may be recurrent cases among some individuals.
Got it. Well, the reason I ask is, looking at the numbers, 551, 190, 33.9 on the per 100,000 population. Rates per 100 population.
Mm-hmm.
And can you find the right slide? I just want to make sure we're talking from the same document.
And that's across all of California.
Okay. The 551 is per 100,000 population?
That's right.
So I have to multiply that by 10 to get to per million, and I have to multiply that by 40 to get to that number by 40 to get to the statewide population numbers, yes?
Yes.
Well, to your point, Supervisor, I mean, they're not inconsequential numbers is the point I'm trying to make. And these numbers track how, again, as against our Santa Clara County numbers in your assessment?
That Santa Clara County has remained roughly around the California state average for all 3 of these STDs. So as it's risen across the entire state, it's risen in Santa Clara, but not any faster here than it has in other places.
So if I take my calculator out, my high-tech public health tool here, and do the math real quickly. If I add on this slide 551, 190, and 33.9 for these three STDs, that's totals close to 800 per 100,000 in population. And if I round our Santa Clara County population to roughly 2 million at this point, that means I have to multiply by 20, which means that I've got 16,000 folks in a given year.
Affected by STDs. It's very possible, yeah.
And even accounting for recurrence over a period of 2, 3, 4, 5 years, we're talking many tens of thousands of folks.
Right.
Okay, thank you. Thank you.
So we need to do more. I think we need to do more.
We do. I think we started with adding resources to our HIV and STD control program, including the addition of a STD controller, Dr. Lewis, to lead the effort. I think that was important.
Very important.
And I think that we do have relationships with custody health, with behavioral health, with Valley Medical Center, with primary care. And even though I usually remind my colleagues about public health being responsible for the 2 million. For the case of STDs, it's incredibly important that we have these collaborations within our healthcare delivery system, because I think we are touching those who are at most risk.
Yeah, no, public health can't do it all, and that's why we need our primary docs and the clinics to sort of do it more in a systematic way, because there's no way we can catch up with public health. So. We have one speaker on this, Dr. Horowitz.
Yes, thank you. I wasn't planning to speak on this, but it's a subject I teach at Foothill College to community college students, and I can tell you they know very little about sexually transmitted diseases, which, to my point, is it really starts in our educational system. I think I remember when I went to high school, we used to have a class in health. Today, if you look at the curriculum, and this is what I would suggest the public health department do, is to research what's being taught in our schools regarding health. I know in Palo Alto, and Supervisor Smitty was on the school board, we kind of eliminated health. We have a class now called Living Skills, Life Skills, which to students is just treated like an elective. They don't take it seriously. I think we need to do more. We need to work with our Board of Education. We need to put health back in the curriculum at some point and make it important to students. Everybody's focusing on STEM, science, math, English. We need to get back to basics, and health is, the most important thing. You ask parents what they want from their kids, they want them to grow up to be healthy and happy. Let's teach them health in the schools, and let's make sure it's being done. And I think that's where it all starts, and we'll do a lot more in prevention. Thank you so much.
Thank you. Then Supervisor Smitty will make a motion to approve that report and move it on its way. Item number 11 is receive report from Health and Hospital System relating to Measure A funded Center for Population Health Improvement.
Hi, good afternoon, everyone. Supervisor Yeager, Supervisor Smitty, and members of the committee. My name is Dove Morocco. I'm the Chief Innovation and Improvement Officer, as well as the Director for the Center for Population Health Improvement. I wanted to do a little special presentation today in terms of talking about where we were in terms of when we started back. And actually, if you look back in terms of the orientation, in terms of what you've been provided in terms of supplementary documents, I provided some information on our strategic plan, which looks backwards a little bit in terms of what our initial promise was when we were started and how we're moving forward. And I also included some of our ongoing projects and demonstration projects. And the purpose of the demonstration projects especially was to orient you in terms of some of what's possible, in terms of what we're capable of doing as a department. If you remember kind of going back to the beginning of when we were funded, and we started late in 2014, our emphasis was really on improving the data systems. So we had implemented EPIC recently. There was a lot of information coming forward in terms of data, but not really usable yet in terms of how we would make changes. And when I listened back to the HHC presentations that we did previously, there was a big emphasis on wanting to turn that data into actual usable information to evaluate what was working and what wasn't. Of course, there was a big emphasis on privacy. And so I wanted to kind of demonstrate how we've evolved over the past few years, and also talk about how we're going forward with sustainment to actually make sure that we're building the capacity to support the health and hospital system for years to come. So you can kind of see in the beginning there, we focused really heavily on data analytics. Years 1 and 2 was all about the Epic Data Warehouse. We brought on a lot of contract staff and then eventually became actual staff, and which ended up actually helping to launch the data analytics unit for HHS, which has been really useful in supporting a lot of what we've done. And then really what we've been doing a lot more lately is actually using the data, and when I say data, I really mean more so information, both qualitative and quantitative, bringing those together. We've been partnering with a lot of different agencies, developing some really strong relationships so that we're able to collaborate. And when we do evaluation, so when we actually are looking to see what's working and what's not, it's going to be coming forward from the departments themselves. We never wanted to position ourselves to be, coming from that point of view of the changes. Actually, we want to be able to partner. So I'm going to focus, instead of talking about custody, which we've talked about a lot of our work before, HUMS, which became a Whole Person Care project, just on one project in particular. So I wanted to showcase this project because you'll see we talk about our population health improvement cycle, which is something we developed uniquely here to go through and identify where are the gaps in terms of what the needs are in the community, and as well as what we have in terms of resources. So if you remember back early on, one of the first projects we worked on was really in supporting that bridge between public health and care delivery, was on Black Infant Health, the Nurse Family Partnership, CPSP, and CCS. This is a great example because it really snowballed. It started as really just data extraction. It was really, we just pulled data using a report, and we provided it to to the public health department that wasn't able to get the data earlier on. And it was just that to begin with. But later, as it evolved, and you'll see on the next slide here, so basically, you can see the problem that we had in terms of facilitating data access. That was the most immediate need that we were able to see. And we really wanted to make sure that those barriers were facilitated and that we were able to work for that. And so there's some data there in terms of what we were able to achieve. Really, there wasn't just enough time and enough, to be able to refer those. And this was a great example. We brought this forward, and it's actually going to NACHO again in terms of a completed project. Next slide. So here is the average number of women who were contacted and how they went on from there. And then you can see for the Comprehensive Perinatal Services Program, the number of hours saved. These were people having to go over physically themselves to the actual hospital to write down who was eligible for the program. And so we were able to expedite that information. CCS was a great project that we were able to work on with the help with the UBTs, as well to develop an expedited enrollment process. Next slide. This is just the population health improvement cycle in terms of where we want to be on every project ultimately. We don't always achieve this in terms of every project. It's not always needed. So for example, if we look at a population in need, so we may look at high-risk pregnancies, or we might look at people at high risk for certain STDs. What we want to do is segment that population, collect as much quantitative and qualitative information. And when we talk about qualitative information and quantitative, what we're looking at a lot more is really more of the community-based participatory research. So instead of looking at surveys or even just looking at, going into a community, collecting data based on them and just getting information and doing things, we want them to be a part of it. And we actually made a strategic hire recently of someone who's, her name is Sophia Gomez, who's actually been working with Dr. Lewis in terms of the STI clinic waiting room, and we'll have more information at a later time that will come from public health in terms of the results of that. But ultimately, we want to be able to identify the needs of the population, and we call that, many of you are familiar with need finding or design thinking, but really co-designing the projects, the implementations to be able to help the community. It is somewhat of an error to think that we have the ability ourselves to design a program or an intervention for a population that we know little about. We are not always a part of that population. We want to identify the gaps. You've seen some of CPHI's ability to identify current resources. We call it asset mapping. We saw it before whole person care, when we were looking in terms of really what intensive case management programs did we have before we go out and creating a whole bunch of new ones. Let's find out what we have. Then where we really wanted to get to really was innovation and improvement. And when I came here almost 4 years ago, that was really where I thought I'd be starting, really with the improvement there. And obviously there's a long way to be able to get to the improvement, because if we're going to make improvements that last and sustain, we need to make that based on good data. Next slide. So I wanted to take the demonstration project here a little bit further. So we've been working with the CPSP postpartum program. And so for those of you not familiar, there's a requirement that they have a visit before the delivery, and then that entitles them to have visits afterwards. So we're looking in terms of evaluating, is there a difference between people who are part of this program and who are not? And what we're really doing is partnering with them to see how we can enable more people to reach out and to visit these women postpartum. And will improvements to this process improve the postpartum visit rates? So we know that to get the postpartum visits all together, you have to have an initial visit before, which has also been difficult to achieve. And it's just that one of those program requirements. So we have to see how we can fix that. And then we're looking to see, is there a difference overall? Next slide. I just wanted to talk briefly about the T2020 collaboration and CPHI. So it kind of came, I think, T2020 became a very important initiative. And when it came along, we looked to see really what's the overlap. We obviously don't want to duplicate. And at the same time, we want to focus on building capacity. At the same time, there was a need to support each of these different initiatives. And one of the first thoughts was, just deploy all of the resources to T2020, and I was willing to do so, but I worked really closely with Andrew James, the project manager, with Alice, Dr. Westphal, and really what they wanted to know was what specific skills and competencies has CPHI developed? All of this investment, what has it yielded that we can actually bring something of value? So rather than just deploy and throw everything at it, we did that very carefully. So evaluation is where we've really been focused on being able to get a lot of strength. And we have a very small contract that was created out of whole person care, which is really grown into T2020, which is about program evaluation. For those of you familiar with evaluation, it usually costs about 5 to 15% of a program is spent on evaluation. This contract, just perspective-wise, is a tiny portion of that. So the idea is to really take all of CPHI, and we can be kind of the boots on the ground to really attend and deploy. You can see we're deploying across all of the different domains. So we can actually yield a much stronger evaluation, as well as learn from somebody and grow that competency much greater. So the contractor that we have is someone who teaches with UCSF. She's faculty, and she teaches program evaluation and implementation science. So we actually have 2 people working closely with her, just kind of understanding how she's going about doing the evaluation. Obviously, there's a population health domain. Dr. Westphal's leading that, and we are staffing those 90-day cycles as he's going through that. The Navigation Center is a really great opportunity for us to really think about more of the participatory methods. And so Sophia Gomez, who I mentioned earlier, she'll be working with that team as well. I think Benita will be leading that one to really make sure we build a Navigation Center that is meeting the needs of the patients that are using it. Care coordinations and transitions of care is one we've been working on closely. We have some meetings set up to work with public health on community and preventive health, so we can support however needed there. And of course, the integrated data is really where we've been growing a lot of capacity in terms of health informatics. So really in terms of where we look at quantitative data before, in terms of correlation and causation, we're really looking forward towards more of, obviously, our future high utilizers. And that was a lot of the data I used to present in terms of, the data extraction that looked very interesting, but didn't really provide much change. Now we're at the point where we have a data extraction team, but now I have staff that really work in advanced statistical methods, and they're able to apply those methods. And we're working alongside Dr. Strong, and we're working along, looking at models related to length of stay and readmissions. Next slide. So I wanted to just share a little bit our strategic plan as it goes forward.
Dove,
here.
unfortunately,
no problem.
we've got some time constraints. So
this is I got the last. You can just skip through these.
No,
so you have
no. We have a plan.
We have a plan B. We have
Okay.
a plan B, and I don't mean that in a medical sense, just to be clear. We do need, I think, to take formal action as a subcommittee to move the inventory items forward to the Board of Supervisors for consideration today. Yes, Mr. Chairman?
That is correct.
All right. Then what I'm going to suggest is that if we can ask for forgiveness on the interruption, but I'm prepared at this time to formally move that we forward these items, and they go without recommendation, so it's just a sunshining exercise today, to move these items forward to the full board for consideration. And then, Dr. Smith, we will have met our obligation to put them on the agenda and move them forward.
Yes.
Great. Then so moved.
Great. I just want to make one comment. It's on item 12C, which is Supervisor Chavez's proposal to purchase AEDs for the jail. I'm not sure if the intent is to use EMS trust fund dollars to fund this item, but that's what I would suggest rather than general fund if we were able to do that. My one comment.
All right. So moved.
All right. Then we will then move those items on. We don't have any public comment unless Dr. Horowitz, did you want to also speak on this?
You're going to lose the vote here in a minute, Ken.
No, this is hold on. No, I just didn't see. Our commission had forwarded a request for staffing at the city team, dental clinic. I didn't see it forwarded. I'm hoping that'll appear at the Board of Supervisors meeting when you discuss the financial situation. Thank you.
All right, thank you. So Michelle, you're all set then with that item, and we'll go ahead and approve item 11 as well, but I know that I have some questions to ask, and we'll continue on with that
I apologize. I was just planning on the 12 o'clock time, and we've run long. So I'm happy to move receipt and approval if that's helpful from a process standpoint.
Then I get you all to myself, Dove. So
you could be here a while. Thank you, Mr.
All right, thank you.
Sure.
Continue on.
Sure. So I just pulled out a few of the different elements from the strategic plan. I wanted to focus a little bit. So our mission was something that we discovered. We went through a pretty rigorous strategic planning process. We really wanted to make sure that our strategic plan was driven by the system needs. And we really came to a realization that we don't really serve the patients themselves. Our customers are really the programs. And we looked a lot at some of the programs and missions of really around in the region where they're able to give data to programs that often are not able to receive them. And so our mission is really to help the programs across our system have the right information, understand the underserved populations in particular, and then through technical assistance, so that's where we actually go out and deploy. T2020 is a great example, where we actually send out like an internal consulting group, and we're able to provide that resource. Partnership development with them, and in developing innovation concepts together. And so kind of a collaborative. Our vision there is really kind of a 5-year off kind of thing, but our goal is to be the go-to place to jumpstart these integrated population health efforts. We see in the future where we want information to be widely accessible to the programs and utilized to drive measurable improvements. And I think that the last point is really the most important, is that the populations our system serves will be defined, their needs will be known, and they will be matched to interventions that they help design or co-design, is what we like to call. And then, of course, they'll be on the road to better health. This is, of course, our future state of where we keep working towards. But we've been strategically working, we use the Baldrige framework in terms of how we integrate our management system there. And we feel like we're getting there one step at a time. Next slide. This was kind of a key exercise, and this is out of Baldrige as well, is to identify what is our core competency. So organizations are not typically organized very well to achieve performance excellence. We're very much aligned to do well in our individual silos. And so thus working across agencies is something that we're designed well to do. We identified these 6 core competencies as areas that we wanted to grow to, areas that we have a lot of interest in. When we talk about evaluation, I mentioned some of the growth that we're doing there. Doing program evaluation well is difficult, and I think T2020 provides us that opportunity to partner with an expert and to really provide that value. When we talk about health services research, it's really changed quite a bit to where we're looking at that sense of mixed methods. So really bringing in, again, that type of community-based participatory. So we're actually able to do some of the more innovative methods there. Next slide. This was kind of one of the more interesting parts of our process that's still not quite done, but what we did is we conducted a series of interviews with the leadership of all of the different departments. And what we wanted to do is make sure that our areas of work were mapped closely to the areas of need identified by the departments. And so through what other methods we could, a lot of the department heads were busy, but we were able to get quite a bit of information. And one of the key areas on the right you'll see were really what we heard from each one. And we did these qualitative interviews with the departments, and we were able to hear these themes that resonated across. And so that we knew that if we developed our strategy based on the system needs, that we were most likely to succeed in terms of meeting the goals. Next slide. This is our last slide actually here, and this is where we move into kind of the next steps. And we specifically left our goals for the next 3 years a little bit loose, but we have really our key areas of work. So obviously population health improvement. So we work across that cycle. So whatever you define your population as, and you'll find, depending on whatever agency you're talking to, they'll very clearly articulate to you who their population is. You talk to, obviously, the public health department, it's the 2 million. Talk to VHP, they're interested, of course, in the covered lives. It just varies very much. And we're always looking at that bridge and supporting in terms of really where is the most need. And so information translation is really where we've kind of really focused a lot of our efforts, because that's where I think the biggest needs are. So when it comes to quantitative data, there's a lot of need in terms of being able to take that data and turn it into something useful. We've been asked quite a bit to provide data, and we're no longer the department that provides data. We can pull it and give it to them, but it's not meaningful without really some analysis and information on how to use it. And that's where we've been able to partner with the CMIO and work. And then qualitative data, I'll just start with a little bit of what we've been working on there, which is really how do we get information from the programs, also the participants. So we've been working with Dr. Lewis in terms of having somebody develop surveys of patients in the waiting room. And I think the survey was extended for 2 months to get more data. And we're just starting to get a very early understanding of why patients are going there and other places. And I think that's the kind of information that will yield. And I think the biggest, most difficult part is to kind of put away our own bias of self-determined health. We have our own beliefs that really do determine how we go about doing certain things. And the programs that we develop from this point forward, I'm really pushing that we start the innovation part is really that it's really designed by those who are the ones most affected by that. And those are kind of the 5 themes there. You have the strategic plan as a whole to look at. What you're seeing also when you see our actual in-progress ones are the ongoing projects. What you're missing too is, of course, all of the ones that are leading to it. So we have this tremendous amount of work coming at us in terms of potential projects. And what we're always looking for is this just a data request? We're able to send them to the right place. Is this just a connection that they need? And that's something that we do, and we don't even really, we have to do a better job of counting and of really, because we get so many requests of just kind of who from this department can help us with that. And that is really one thing that really one value of having a Center for Population Health Improvement at the health and hospital system level that's really valuable. Because everybody knows a great deal about each of their own individual agencies, and where we hope to continue to add value is spreading innovation and information across the departments. Thank you.
Wow, that's a lot and very exciting. And certainly this committee has been following CPHI since the very beginning, and I think you have a small staff, but a very motivated one.
They're the most motivated staff. They're very exciting to work. Unfortunately we lost Pam. Went back to public health 100%. We shared her with her, but it gives us the opportunity to backfill the position in terms of having a full FTE. We continue to work so closely with Pam. We have 2 projects actually going to the IRB June 1st, just to make sure for the improvement. So we want to disseminate a lot of what we learn, but Pam continues to serve as that bridge between public health, and we're really grateful to have her for that time.
Well, I was going to ask if you felt that departments were taking full advantage of your department, but it certainly sounds like you're getting many requests.
I can't blame them. To be honest, we never really fully articulated what it is we did. And that was really a journey we had to kind of fulfill. We couldn't really articulate well to a department, okay, these are the types of services that we offer. We do information translation, we take data, we can be deployed on special projects. We really didn't identify what our core competency was, and because of that, people didn't know how to utilize us. And it's hard to, without really having that clear vision that took us some time to develop, I think that it's understandable that it took some time. And now we're getting a lot of work requests. We have to refine them a lot. Sometimes we used to call it kind of having to beat the bushes for work, but it's partly because the staff that I have just really like to work.
And you want to talk a little bit about T2020 and?
Sure. So I think initially it was just a little bit of confusion for the department in terms of how do we fit in. There's often a lot of new initiatives will come over time, and what we really want to focus on is making sure that each time something came forward, we wanted to have something of value to add. So when there's something like T2020 comes along, we want to be able to say, oh, hey, this is what we have to add to this, but we don't want to dismantle everything in favor of just throwing all of the resources there, because to actually accumulate the wealth of resources that we have in terms of the knowledge, it's been a lot of investment. It's actually been a lot of those Measure A dollars in the beginning, where we were able to train people in EPIC, we were able to train people in evaluation, qualitative research, all of those areas. We want to make sure that we kind of do a continuation of building capacity, and at the same time leveraging those resources when they're most needed. And right now we see a critical opportunity. None of the staff are here right now because they're all at the T2020 launch right now. And so I think that's a good sign of a balance between the two.
And only because we were talking about STDs, and you had, I think, referenced it a little bit when you were saying questionnaires that Dr. Lewis was handing out. And I certainly noticed that in the report, you were talking about trying to understand why some patients would go to the STD clinic rather than to their primary care physician, and trying to understand what was going on there.
Yeah, so we've done a couple of things in that area, and we've approached these, it hasn't been as easy as one would think to just simply go into departments, find out what's going on. It's been, first of all, we've partnered really closely. We go to the primary care. We've just been added to the primary care operations meeting for their T2020. So we just go and listen to hear what's going on. What are their kind of ongoing concerns? And they have a lot, right? And then we've been partnering with Dr. Lewis. We have our qualitative researcher. They developed a survey, and it's been refined several times. And they've been collecting data in terms of why are patients going there, why not. We've been talking to the patients, bringing that information. But we partner with them so that they can bring the information forward when it's ready for that. And right now, it's still in the preliminary phases. And so it gives us an understanding so that when we do go to ambulatory care and have a request, we're really aware of what's going on in terms of their priorities, so we can fit it in to make it a win for them, as well as fitting in within and partnering and getting the trust of people who are wanting to add capacity and understand the needs of each of the clinics. So that, the clinic that the STD and the HIV clinic and the Crane Center, two different clinics, we want to make sure we have a full understanding of the need. And it's required a lot of time and investment to begin to get there. But I think at the end of the day, we'll have those relationships where we're actually able to bring forward something that's more useful and sustainable.
I could certainly ask a lot more questions about all the work in this one as well, but I know our time is limited.
I think it will come forward from public health in terms of they are just digesting the data themselves, and I think we're looking at a secondary plan to see, this data told us this much information, but we're talking to the patients themselves, which is really key. These are the ones who are going to these clinics. We can find out, but it's a little bit like an onion. Like, we can understand maybe one layer. Being able to really understand the needs of these patients, I think we're going to be really, really a long way towards kind of peeling the onion there. But we want to get at least a little bit closer and at least start to take away some of our own bias towards why we think that they do this and so forth. And we have those relationships in custody, obviously, as well, where we've been working, and of course, a lot of the knowledge and relationships with behavioral health.
Renee, I'll give you the last word if you...
Thank you for all the work. I really appreciate, obviously, Dove and the team. Like you said, they're a very happy and motivated team willing to help.
That's excellent. All right, everyone. That will do it. Michelle, we're all set. I always like that answer. And so we are adjourned then until June 20th here at 10 a.m. Thank you for being here.